All right. Let's talk about cerebral aneurysms and arteriovenous malformation. Now, an aneurysm is always going to be a ballooning of an artery. All right. And you might remember this as I like to draw that picture. Oh, wait. How do they do this on YouTube? See that picture? That's not my belly. This is a picture of an artery with an aneurysm. Okay? Now, the problem with aneurysms is I should have blood flow going through here. All right, straight through. But when I have an aneurysm, it gets in here, and it likes to get in here and jiggle around. Makes that blood jello we've talked about. All right? It doesn't have this nice flow because it gets stuck over here, and blood just keeps going by it, and platelets, and it keeps clotting, and it jiggles, and guess what I end up with? Usually a clot. All right? I can have rupture of an aneurysm, which would be absolutely deadly. But aneurysms itself, you could have an abdominal aortic aneurysm, an aneurysm in your brain, and typically, though, the scary part is that aneurysm in your brain might not give you a whole lot of forewarning, and that's scary. I've known quite a few people. I went to high school with a girl that had an aneurysm at 17, and I don't even think she's alive anymore, but she lived to be in her 30s. Just wonderful family, took such good care of her, but it was just like that, just instant. Aneurysms are always a scary thing to talk about because anytime anybody has a headache, oh my gosh, it's a really bad headache, it's an aneurysm. But that could be a precursor as having a series of bad headaches that are abnormal for the person. Your book says an aneurysm is an abnormal ballooning of the artery wall. It may be congenital or caused by a weakening of the artery wall from chronic hypertension. We talked about that. Just woof, woof, woof is what I should have, and I shouldn't have woof, woof, because all that high blood pressure, that pressure against your arterial walls is going to cause those microscopic tears, and it's going to cause this ballooning. And I don't want that. I don't want the rupture, and I don't want what can happen inside that little ballooning and that little clot, jiggle, making that blood pudding kind of thing, that blood jello. Okay? So, I want to make sure that, well, sometimes I can't make sure. All right? These are kind of scary things. It says a subarachnoid hemorrhage, which refers to bleeding in the brain below the arachnoid. Think back to where your meninges are. That should have been in the couple of chapters ago, but go back to AMP. Remember where your dura, okay? Remember your dura? Think about where your arachnoid space is. Go back to that, and when you can look at those things and you hear subarachnoid or wherever it may be, you're going to be able to place it. All right? Sub means below, okay? So this is below subarachnoid, below the arachnoid. Often causes rapid onset neurological deficit and loss of consciousness. If I've got a bleeding in the brain, for one, that can't really happen for me because the blood in my brain is what nourishes my brain, so I have infarcts and necrosis. Plus, I only have so much room in my brain, and then I've got a lot of pressure. So there's many things that are wrong with a brain bleed. A leaking cerebral aneurysm may cause a severe headache. However, sometimes bleeding is slower, producing a more gradual progression of headache, neck stiffness, and other neurological signs such as blurred vision. So, I hate to even say that because that makes it scary because it's so inconspicuous. So, anyway, stroke prevention. Back to strokes over here, which, has a lot to do with this aneurysm. When we're talking about aneurysm, I could kind of see that as talking about what we would call a hemorrhagic stroke, but we usually refer to those. Anyway, they're both bleeding in the brain, okay? So when I think about an aneurysm, I think about an artery that's been ballooning for some time, regardless of what it's caused, and it's ruptured. So when I think about cerebral aneurysms, even though it doesn't talk a lot about over here, or just anything called a hemorrhagic stroke, we may be referring to those as aneurysms. Just know what an aneurysm, what we're talking about, the aneurysm, and know the difference between an infarct and a bleed. Okay? Stroke prevention. Many strokes can be prevented by either surgical procedures or by medical management. If I've got high blood pressure, lower it. If I've got high cholesterol, lower it. If it's congenital, I may have to have surgery. Always goes back to preventative care. All right? We always go back to eat right and exercise, drink plenty of water. Aneurysms and AMVs, which is your arteriovenous malformation, can sometimes be surgically corrected if found before rupture. Sometimes they'll go in there, and I don't know if it talks about it in here or not, but sometimes there's little things they can put, look like a staple on it. Yeah, we're going to get over there. Yeah, we're going to get over there eventually. So, pay attention to that. Warning signs of a stroke, put 400 stars around it. Yeah. Okay, clinical cues, always pay attention to those. We won't go over them because we're going to have 1,000 videos in this chapter if we do. On table 23.1 on 532, you're going to see some drugs commonly used for CVAs, which is cerebrovascular accident, which is a stroke. Okay, TPA is something that we didn't used to do in this hospital, but I found out recently that our ER doctors are doing it now. TPA is the only thing that we're going to consider as a clot buster. There are so many problems that could arise from TPA, but it's also saved millions of lives. So if I've got somebody that comes in with a stroke, they're active in the stroke, I would definitely have to have a consent signed, because I could give you or the doctor could give you TPA. It's always a doctor. A doctor could give you TPA and kill you with it. It is so likely to cause even more bleeding. All right. So here's what the scary part is. If you've been determined to have a stroke, they need to do some kind of brain imaging first to make sure it's not hemorrhagic. If somebody gave TPA with a hemorrhagic stroke, the person will bleed to death quite fast. All right. The whole purpose of giving TPA with an infarct or cerebrovascular accident with necrosis, lack of oxygen, is because I've got a clot blocking those vessels, causing the infarct, okay, causing the necrosis. So the only reason I would give the TPA is to bust that clot, and it's the only thing that actually busts the clot. When I talk about things like blood thinners, which are not actually thinning the blood, they're platelet aggregators. They keep platelets from sticking together. When I'm talking about those things, they don't actually get rid of a clot. TPA does. It breaks it up. But think about, if it has to be that powerful, how dangerous it could be. So there's definitely consent signed. I don't want to be sticking these people for labs. I don't want them to fall. I don't want them to do nothing. They just want to lay still. All right? So, and if a doctor gives TPA in an emergency room, another hospital won't touch them. So something to keep in mind. You'll also see aspirin, Dilantin, nimotepine, not something I'm familiar with. Aspirin's a platelet aggregator. Don't worry about those just yet. I don't know if they're going to be in the test or not. Look over them. Definitely be familiar with TPA, okay? Signs and symptoms, you've got on the page before, the warning signs of a stroke. Make sure you're looking at this. You know the definitions of hemiparesis and hemiplegia. Make sure you know dysarthria and aphasia. You're going to see those words your whole life. And when you're talking the talk, you've got to know the lingo. So when you get to the test, you're going to see those words. You're going to need to make sure that you know the difference between them. Okay? So I know that we've all talked about stroke before. You guys have seen people with stroke. If I've got a stroke on this side, then I'm probably going to have the deficits on the opposite side. So if there's a stroke on the right side, I'm going to probably lose function on my left. Just depending on what I lose is where it is in the brain. Okay? I'll probably see facial drooping, confusion. Word salad is a huge one. I'm saying things that I think make sense, but they do not make sense at all. They're just random words. I don't know where this is in the book, but it's in here somewhere. Okay? Dysarthria is difficulty speaking. Remember that word. You'll see it at some point. Okay? So they're trying to talk, they're trying to move, they can't move, there's drooping. All right? The word salad, make sure you know all those things. Okay? Clinical cues, always look at those. I'm going over to another sign, and it could be the pupils. All right? So know your... Oh, here's a good one. Spatial perception deficits may cause the patients to totally neglect input from the affected side of the body, called unilateral neglect. She must be taught to attend the body parts on that side of the body to protect them from injury. That's a very good point. This is usually for people after they don't have feelings, so they kind of forget about that part of their body. You may see questions along those lines. You know, I need to make sure that my stroke patients are tending for the side that they can't feel. And I've had patients like that before. Right? And then we have all kinds of problems. Make sure you know the word agnosia, which is inability to recognize an object by sight, touch, or hearing. All right? I could hold up a card with a dolphin on it, and they may say horse. All right? they may, and then they get, sometimes they just get, and you say no, and they just get agitated because they know they're not doing it right sometimes, and sometimes they don't. I may have some problems with my pupils. All right, I may have a pupil that's dilated on one side and one that's pinpoint. I may not have that perla I'm looking in. I don't have reaction, whatever. Okay, if somebody comes in with all these other symptoms or some of these other symptoms, and I get my pen light, I'm flashing it in their eyes, and something looks wrong with their pupils, remember, I've always said to you, the best thing to know is what's normal. All right? I need to know what's normal. That way, if it's not normal, then I know it's abnormal, and then I can figure it out from there. Okay? So I know it's normal for both my pupils to react the same way and be a certain size, 2 or 3. All right? So if it steers away from that, then I know there's a problem. All right. Apraxia, no, that one, the ability to carry out, learn sequential movements on command. You can tell them to move their arm, and they move their foot. All right. Diagnosis, I'm always going to, anything with the brain, I'm going to go back to CT, scan, and MRI. And you better believe they better be doing those before they give TPA, streptokinase. I'm going to look at blood levels. I could be doing Doppler studies to see if I can find a clot anywhere. There's all kinds of things that I can do for a stroke, but they need to happen fast. All right? So if somebody comes in with complaints of stroke, they have a certain amount of time before they get them to, there's this plan that ERs have that say you've got 10 minutes to get them to MRI, you've got this amount of time, just like they do with heart attacks. They have a certain amount of time. The windows are usually a bit better than it is with heart attack. Heart attack's very, very fast. Sometimes with CAT scans, I've got more leadway, but I still don't want it to keep on going and going and going. If they're going to give TPA, they need to do it pretty soon. Okay, treatment. When a stroke is suspected, the first priority is to maintain an open airway, and that is with anything, okay? All you people who are going out there to be emergency room nurses, ask Trish, Nurse Roysden, ask her what's the most important thing. It goes to your ABCs, and I know sometimes CPR gets away from that. We compress first, but when it comes to testing, there's absolutely no way I can survive anything without an airway. I don't care about circulation right now. My airway, I have to have it open to have a breath to circulate oxygen in my blood. Makes sense. So anytime I come in with the ER with anything, I'm looking for an airway. So I'm going to make sure that they can breathe, all right? I want to take their clothes off if they're constricting. If they're drooling, make sure they're not going to aspirate on it. Protect that airway, okay? Once under medical care, supplemental oxygen is started. I'm losing oxygen, so I want to supply some more. If breathing is impaired or the patient is comatose, I may have to put in an artificial airway. I may have to intubate. It just depends on where they're at. If they came in hypertensive, I need to get some kind of antihypertensive in to bring that blood pressure down. We're going to start looking to see what has caused this stroke, okay? First and foremost, airway, of course, all right? And then we're going to look at underlying causes and try to bring them down. I have circled in my book 2 IV lines, all right? And anytime you go anywhere and you learn about strokes, you need at least 2 IV lines. I promise you that. I don't know when you'll see it, but you will see it again, okay? And it says I'm going to administer normal saline. I'm going to look at the electrolytes in labs. I'm going to do all kinds of labs. Look through there. Look at the labs you're going to do. I may do something. I may do regular lab CBC, a chem panel. I'm definitely going to be looking at clotting times, the PT, INR. I'm going to be looking maybe at a D-dimer, which is indicative of clots. Lots of things I'm going to be doing in there. Look at those. Let's see here. Notice under the TPA on 534, it says that I only have 3 to 6 hours to administer that TPA from the onset of symptoms. So that's why I'm saying in the beginning, we may have a little bit more time than we have with a heart attack, but if I'm going to be a doctor that's going to give TPA, it's going to be pretty soon. Now, why does that make any difference to you? Because you're the one that's left taking care of the patient that's just had TPA, and you have to put on bleeding precautions. And I'm telling you, every precaution you can think of to keep them from getting hurt or bleeding, they're going to be on, all right? You're going to have to watch from bleeding around their IV sites. Oh, my goodness, you're going to have to watch for so much. Let's see here. The drug is not administered. All right, here's a big one for TPA. The drug is not administered to anyone with known risk of bleeding or who has intracerebral bleed. We've already said that. Why would I give something to you to bleed more when I'm already bleeding up here? And that's why I need a CAT scan or MRI before I ever get TPA or streptokinase, whatever. Okay? Safety alert on cranberry juice. Pay attention to it. All the safety alerts are a big one. I don't know how much you get into medications during your med-surg test, so I won't hit on those very much. Look over them if you think you need them. Typically, I always did them just on the farm test so you could focus on the med-surg stuff. But if they're going to be on there, take a look at them. Surgical procedures. Let's see, about 1/3 of strokes can be traced to obstruction of any one of the 4 arteries in the neck that supply blood to the brain. That's where I'm going to go back and have Dopplers. Okay, they're going to go in ultrasound to see if I've got a blockage somewhere. I could end up with an endarterectomy or a balloon angioplasty, some way that I can get blood flow back to the brain. It talks about MRSI, which is mechanical embolus removal in the cerebral ischemia. Look at it. You don't see it a lot. I don't know. You may see it again. I don't know a whole lot about MRSI. Take a look through there. Just get a brief familiarity with it. Next paragraph, it says a cerebral aneurysm may be repaired during a craniotomy by placing a clip around the stalk of the aneurysm. And you do have a little diagram over here. They can do the same thing with a AAA, an abdominal aortic aneurysm. I said that just a little bit earlier. Sometimes I can go in and clip it, and if you'll notice over there, I still have that balloon and that pouching, but when I put that clip on, then it kind of restores normal blood flow, and, you know, I don't really have that problem much anymore, okay? That little aneurysm could still probably burst, but all I'm going to lose inside of there is the blood that's collected, okay? There's other things they can do over there. There's a wrap. I don't know that I've ever seen those. That coil, I've heard, is a really, really bad thing. It says down here, coils of wire are curled into the aneurysm sac, filling it. Electricity is sent down the wire to break the wire off and leave the coils inside the aneurysm. Thrombosis completes the solidification of the aneurysm, effectively eliminating it. So all I'm doing with the coil is winding it up in there, letting it sit there, letting it clot form around it, and then I don't have any more turbulent blood flow inside the aneurysm. Now, that sounds a little crazy to me. Don't particularly like the idea of that one. I'd rather have the clip itself, but, you know, I don't know. I've heard some bad things about it. But anyway, as you can see, though, all I'm doing there is causing a clot to fill up that space, so I don't have any more turbulent blood flow. Okay? Complications, extension of a hemorrhage or a rebleed. If initial symptoms were caused by leaking cerebral aneurysm, rupture is a danger until the aneurysm is repaired, obviously. If I'm having a stroke because I've got a bleed going on up here, okay, a small bleed, if I have a big aneurysm, a lot of times I don't have time for repair, okay? With a big aneurysm in the head, people usually go to sleep and they don't wake up. But if I've got a slow bleed causing this CVA, they can go in. I have to be careful because if I've had one bleed and it stops itself or whatever it does, I can bleed again. So I'm not going to say this person is cured until I go in. They take the top part of my head off and they fix it, okay? Seizures, absolutely. I know that if anything happens with the electrical activity, impairment of electrical activity in my brain, I can have a seizure. Hydrocephalus, break it down. Hydro means water, cephalus means head. If blood has leaked into the ventricular system, it interferes with the reabsorption of cerebrospinal fluid, causing hydrocephalus. This is more common when a subarachnoid hemorrhage has occurred and may be necessary to prevent increased ICP by shunting the fluid out of the brain. Now, we said the other day on the last videos, my brain, the fluid around my brain can only be so much. All right, I'm constantly making cerebrospinal fluid, but my body reabsorbs it. I make more, and so on and so forth. Okay, but I have this natural consistency to it. So that means that if I have a bleed in my brain cannot reabsorb the cerebrospinal fluid that it should be, but my body keeps making more. And you see what happens? I get a lot of fluid in my cranium. There's nowhere for it to go except for pushing on my brain. That's not a good thing, all right? So again, we could see the orbital, I won't even say orbital edema, but the pushing out of the orbit. Again, I could have some kind of protrusion of my brain out my foramen magnum, where the brain stem is. There's only so many places my brain can go, okay? So, gotta watch that one. Look at the phases of strokes. Those are big here recently. It says your care of patients after a stroke can be divided into 3 phases. Phase 1, or the initial phase. Phase 2, which is concerned with rehabilitation. And phase 3, during the plans are made for continual care. So you'll see. I'm sure you'll see those again. If you don't see them on this test, you might see them on the NCLEX. If you don't, you'll see them again in practice. Okay? Know your phases. My phases is my phase 1's when it's happening. What am I doing to stabilize you right now? How am I treating you during this process? Phase 2, I'm going to rehab. Okay, rehab for months possibly. And then stage 3 is how I'm going to live the rest of my life. What can I do inside my home? How can I adjust my way of life to deal with what has been left over from the stroke? Okay. Again, I won't touch on nursing, diagnosis, and planning. I always think about a person with a stroke, how they look to you laying in that white room with nothing on the walls in that bed. And what would I be worried about? I'd be worried about their airway. I'd be worried about their circulation because they're not up walking and moving. I'm worried about skin integrity. I'm worried about respiratory infections because I know that if I'm laying in the bed, I can get pneumonia. Think about all those things that can happen to that bedridden patient, especially those who cannot move parts of their body. You got it. All right, I'm going to stop this one and come back.